Hi, this is Dr. Gomati here to explain about mucormycosis or the black fungus. An overview about introduction, morphology, taxonomy, culture media, life cycle, epidemiology, risk factors, pathophysiology, clinical features, treatment, and the references. Introduction. It is caused by a saprophytic fungus found in soil, bread mold, animal manure, and rotting vegetation. Rhizopus found in bread mold, Mucormycosis found in soil and rotten vegetation. Morphology. Colonies are fast growing and resemble white to grey cotton candies. Hypae are wide 6 to 15 micrometer. Sporangiophores are long, branch, large and 50 to 300 micrometer. Taxonomy comes under the kingdom fungi, division Zygomycota, class Mucormycotinia, order Mucorales, family Mucormycosis and genus Mucor. Culture media Sabrotes dextrose agar medium and potato dextrose agar medium. Life cycle vegetative reproduction, sexual reproduction and asexual reproduction. Vegetative reproduction, it consists of a mother mycelium. Each fragment split into many subunits. Each subunit have a capability to grow like a new mycelium. It's like fragmentation. And an asexual reproduction mainly takes place in three spores: sporangiospores, chlamydospores, and odiospores. Sporangiospores germinate by three steps: sporangiospore elongation, columnoplasm, bursting, and germination. In epidemiology, internationally, 1% of patients with low immunity and estimated prevalence of mucormycosis is around 70 times higher in India than in global data. High mortality rate of 50 to 100%. Risk factors. Diabetes with ketoacidosis is very predisposing. Hematological malignancies like leukemia, lymphoma, prolonged neutropenia, deficient T cell immunity, and low birth weight. Prolonged use of steroids, desferoxamine therapy. Fungus thrive well in iron-rich environment. It thrives well in acidic pH and glucose-rich medium. It promotes fungal growth and impaired neutrophil chemotaxis, while lactic acidosis decreases the phagocytosis. And also in bone marrow or organ transplantation, chemotherapy, intravenous drug uses. Pathophysiology, it mainly involves angioinvasion, vessel thrombosis, and the tissue necrosis. Clinical features: 5 different varieties: rhinocerebral, pulmonary, cutaneous, gastrointestinal, and disseminated variety. Predisposing factors and the site of infection. In diabetic ketoacidosis, it will be rhinocerebral. In neutropenia, pulmonary and disseminated variety. Steroids, pulmonary, rhinocerebral, and disseminated variety. Malnutrition, GI tract will be involved. Trauma, catheter, skin laceration, and cutaneous, subcutaneous. Desferoxamine will be disseminated variety. Rhinocerebral, it is highest frequency and mortality rate, 50% of cases in diabetes mellitus patients and 50% of total cases of mucormycosis usually occurs during the episodes of diabetic ketoacidosis. Clinical features: nasal stuffiness, epistaxis, facial pain, facial cellulitis, anesthesia, headache, and lethargy. Later, proptosis, chemosis, and ophthalmoplegia. Fever and confusion will be there. Characteristic features like black necrotic scar and the nasal turbinates or palate. Complications: cavernous sinus thrombosis, multiple cranial nerve palsies, visual loss, frontal lobe abscess, carotid artery or jugular vein thrombosis causing hemiparesis, rapid death. It grows rapidly and releases airborne spores, enter through the nose, oral mucosa and throat, attack people with low immunity. Diagnosis: punch biopsy of lesion followed by fungal strains and culture. Histology: characteristic broad branching hyphae of rhizopus invading the tissue. CT or MRI of head reveals air fluid level in the sinus and involvement of deep tissues. Pulmonary occurs in patients who have prolonged neutropenia, patients on chemotherapy, leukemia, treatment with desferoxamine. It is very difficult to distinguish from an invasive pulmonary aspergillosis. Symptoms like fever, cough, dyspnea, chest pain, pleural effusion. Species of Mucormycosis about 3 to 11 micrometer in size causes the pulmonary variety. It is mostly through inhalational and cutaneous variety. It is a very life-threatening disease. Radiological features like consolidation, isolated masses, cavitation, wedge-shaped infarcts will be seen. CT scan is the best method to detect the extent. Cutaneous. Trauma is the predisposing factor. It is locally invasive. It may lead to necrotizing fasciitis, mortality rate up to 80%. Reddish and swollen skin, skin trauma, ulcer, painful patches of skin are seen. Fungus enter through the skin. Patients who are low IgA and IgG antibodies, skin therapy and transplantation will be predisposed. It has very poor prognosis and surgery can be done depending upon the area involved. Gastrointestinal transmission through the inhalation of spores, commonly seen in malnutritionist child and immunocompromised patients. It involves stomach, colon, ileum are the most commonly involved. Symptoms may vary depending upon the parts of body involved. Common symptoms such as abdominal pain, bowel obstruction, nausea, vomiting, bloody diarrhea, dyspepsia, and which has very poor prognosis. Disseminated variety, it is hematogenously spread. Pulmonary mucormycosis has the highest incidence of dissemination. Most common sites are brain, spleen, heart, skin, and other organs. Rare fatal complication disease. It involves multi-organ and the symptoms are mental status changes, occurs who are already sick from a medical condition. It may lead to coma also. Treatment mainly involves the antifungal medicine. Usually amphotericin B is the first line of drug of choice for most of the cases. Surgical debridement of necrotic tissue. Some suggest hyperbaric oxygen therapy for inhibiting the growth of fungal spores. References. Also subscribe my channel for more videos. Thank you.